Good evening, ladies and gentlemen. Welcome you all to this webinar on ECG Basic and Beyond. This is the 34th lecture of this series. We'll talk on ECG in clinical practice. We have got our course directors with us, Professor Abdul, Wadud Chowdhury, and Professor Atahar. We have got our international advisor, Dr. Rafiq Ahmed sir with us, and a number of faculties with us. Our today's session has got two parts. In the first part, Dr. Abu Muhammad Shafique will talk on ECG in clinical practice. In the second part, Professor Chowdhury Hafizul Hassan will talk on ECG in clinical practice. First of all, our first speaker, Dr. Abu Muhammad Shafique. Dr. Abu Muhammad Shafique graduated under Dhaka University in 1992 and later had his MD in cardiology from under Dhaka University in 2006. He worked in NICVD from 2000 to 2006. Later on, he joined as chief consultant in the Jia Heart Foundation of Dinajpur. Later also worked in the United Hospital, and in between, he also worked as consultant in the Max Hospital, Chittagong. Now he's working as a consultant of consultant cardiologist in United Hospital. He's also a good organizer. He's an elected member of the Executive Committee of Bangladesh Cardiac Society, and is involved in number of platforms with professional teaching. At the beginning of the session, may I request Professor Abdul Wadud Chowdhury sir to say a few words about today's session. Abdul Wadud Chowdhury sir, please.
Good evening, everybody, and Assalamu alaikum. Welcome to today's session. Today, we are going to have a presentation from a very versatile cardiologist. Shafique, as I know him from his student days, I was one of his teachers. I would say that the versatility is something that characterizes him. And he also is a very brave cardiologist. He takes up challenges, faces them, overcomes them, and whenever he is in trouble, he doesn't get demoralized. He comes back again to win back again. And so I'm hoping to have a bombshell experience, bombshell exposure from his ECG in clinical practice session today. Let us hope we will be enjoying this together. Welcome, Shafique.
Thank you, sir. Now, Professor Dr. Abu Muhammad Shafique, it's your time. You can share your presentation.
Thank you, sir, for very kind introduction. Actually, it is more than me, what was already been introduced in such a way. Thank you, today's course director, panelist, and definitely international faculty, Rafiq sir, giant of ECG. So, and all the audience, especially the fellows who are in this session, Assalamu alaikum, very good evening to you all. Actually, I am not that person to talk with ECG. I was asked by Professor Atahar sir to present some ECG in this session. Then I started to collect some ECG and to produce in front of you. First ECG, actually, last 2 days back, I was asked to see a patient having infective exacerbation of bronchial asthma, probably. And then I saw these 3 ECG of that particular patients. And one by one, I'm going to show you. So I want to invite someone, fellow, to interpret this ECG. This is very common ECG, and we used to get this ECG in our regular practice. So I want to invite someone, fellow, who can help me to diagnose this case. Someone else.
If any of the fellows are interested, you can raise your hand. Then we can include you in the fellows.
I have seen 3 ECG.
Yes.
This is the first ECG I have seen. Then 2 other. I'll be coming one by one. Anyone volunteer, please?
Anyone please raise your hand? Arafat.
I think
Ribu, can you bring Arafat into the panelist one? Arafat.
Yes, sir. Bringing him to the panelist.
Dr. Arafat, you can unmute yourself.
so sir, can you hear me, sir?
Yes, we
Yes.
can hear you. Okay.
Sir, in this ECG, I can see there is a tachycardia, and the QRS complexes are irregularly irregular. And I think there is a 2F inversion in lead 4, 5, B4, 5, 6. And there is also T inversion is lead 3 and APF. So far, this is my impression about this.
If I want to help you, there is two parts. One is limb leads and another chest leads. So this is your impression is atrial fibrillation, right?
Sir, right, sir.
Okay, fine. And what would be the heart rate?
Sir, I think there is tachycardia, fast atrial fibrillation, I think. Sir.
Right, with fast ventricular rate, right? Okay, let's see the limb lead. What is the problem in the limb lead?
Sir, in the limb lead, sir, there is
Arafat.
lead, sir, lead in lead 2, sir, there is QRS complex is almost at the level of the baseline, and there is T inversion in lead 3 and AVR, sir.
AVR, T inversion.
Sir,
AVR.
T inversion, sir. And there is positive ROF in AVR, sir, also.
Is there anything else?
Positive RF in AVR. There may be, sir, misplacement of the lead may be a possibility, sir.
What is the lead?
Sir, in the AVR, sir, leads should be all the sir waves should be negative in lead AVR, but here I can see the QRS complex is positive there, sir.
Okay. May I go, get the? I can show the next ECG. Then this is another ECG of the same patient.
Go back to the first one.
Okay, sir.
Look at this. Whenever you get negative complex in lead 1, be sure you get
as well as lead AVR.
Lead 2 is not seen here.
Sir, sir.
I see a almost straight line. I'm very skeptical about that quality of ECG. There is very likely that hand limb switchover has been occurred, hand and arm. That is a possibility. And I will have a look at AVR. It shows positive QRS complex. I'm becoming again more skeptical. That's one thing. Second is, before calling AF, look at V1. We are getting P wave like structure in there. Is it P wave or is it atrial tachycardia? That's a possibility.
Sir, right, sir. It may be, sir, atrial tachycardia, sir, or sir, atrial flutter with variable conductance may be a possibility, I think, sir.
Deeply switch over, and also this is not a sinus rhythm. Can you
Sir,
next one?
Same patient and same day ECG was done. And if we see the second ECG.
Sir, in the second ECG, sir, now I can see the second lead properly, sir. And now it is visible, sir. And sir, in 1 and AVL, sir, the QRS complexes are negative here, sir.
AVR.
Sir, one AVL, sir. In one AVL.
One AVL. And in AVR?
In AVR, sir, there is
Positive R wave.
positive R wave also, and there is slight possibility of ST elevation in AVR, sir. A bit elevated, seems to be a bit elevated, sir.
In the same patient doesn't have any chest pain.
Sir, sir.
And this ECG. Now, what is the likely cause? Actually, you have already told one AVL that is negative R wave and positive R wave in AVR. What is the problem? Is it dextrocardia?
Sir, less likely, as there is V1, there R wave is not positive in front chest leads like V1, V2, V3, and there is not progressively decrease in the height of R wave in chest leads, sir. I don't think it is a case of dextrocardia.
So it is a
sir, misplacement of the lead is a possibility, sir.
that is a technical dextrocardia.
Sir.
Is it?
Right, sir. Right, sir.
It is a
Sir,
technical dextrocardia. And this is the original ECG, right? That is really true. There is misplacement of the right and left arm. And this is the right arm and right leg.
Dr. Shafique.
Yes.
Hello, Dr. Achha, can I ask you a question? Achha,
Sure, sir.
this ECG, achha, in absence of the appropriate P waves, that is in case of the atrial flutter or fibrillation like this, when there is no organized correct P wave, how can you exclude the old high lateral MI in this patient?
Actually, sir, I have seen 3 ECG, and later on I could get this ECG, and I thought this could be a high lateral MI. That was in my mind, and I went through the patient's previous ECG. There are same changes, and that was existing. And patient doesn't have any chest pain. Still, I asked to do troponin test, and later on it was found negative, sir. That was my differential diagnosis. But actually, problem is that I could not interpret this ECG. That is why I deliberately asked the sisters to bring the ECG machine, and I did in different combinations to get this sorts of ECG. This ECG. Later on, I could find right arm and right leg displacement can give this ECG. That how I could discover. And this is the problem. It has happened. So we need to know whenever we want to interpret these sorts of ECG. Any comments from panelists, sir?
Rafiq sir.
No, I think you are absolutely right. When you see this in lead 1, a Q wave, and that's a pretty big Q wave, the immediate reflex is to think about limb lead displacement. Also, I mean, it can be a lateral MI, but then you look at V4, V5, V6, there is absolutely no Q wave. So that kind of discrepancy. So the common thing. The problem is right arm, left arm is very easy to distinguish, but when there is swap of the other arm, there is actually algorithm. When I have a huge algorithm, but it becomes impractical to be able to go through that and find out which has been displaced. So the common is that we see at the right and left arm, and that we can diagnose very quickly.
Right, sir.
Yeah.
Thank you, sir. Can I go for next ECG, sir?
Shafique bhai, if it was a case of lateral MI with atrial fibrillation, on that case, what would be the appearance of the AVR?
If it is a lateral MI, then
Lateral
AVR should be
MI
like
with
this.
atrial fibrillation, on that case, the AVR is supposed to be negative. So having a positive AVR with this appearance should bring in the suspicion that it could be a abnormal placement of the lead.
Right. Thank you. Can I go next one?
Yes.
This is next ECG.
No, Shafique, please, previous ECG, please.
Sure, sir.
No, Shafique, actually, what is the rhythm? Actually, fibrillation, flutter, or atrial tachycardia?
Oh, that's the question, sir. Actually, sir, this is, in my view, it is atrial flutter with variable blocks, sir. Because V1, there is P wave rightly seen in V1. And also in V2, V3, P wave is, can be appreciated. So in my diagnosis, it is atrial flutter with variable block. And
What is that?
any expert opinion, sir?
Professor Chowdhury, Wadud, Rafiq sir?
If you look in lead V1, it looks like atypical flutter, but the P to P interval is not regular. I mean, from semantics wise, I can call it atypical atrial flutter with variable block, but for all practical purpose, this patient should be treated as atrial fibrillation and managed accordingly.
Thank you, sir. May I go, sir, for next ECG?
Yes, yes, next is yours.
Okay. This patient came to me 36 years only at OPD with palpitation, tiredness, and vertigo tendency to fall. He had a history of hospital admission with chest pain. And that time, I have seen the previous record. The ECG was that time troponin was negative, and this sort of ECG was there in the previous time. So this is the ECG. Can I get someone else to interpret it? Any volunteer, please?
Any of the fellows or attendees who can attend? Otherwise, we can talk with Arafat, Dr. Arafat.
Sir, I was just I'm just looking at the ECG, sir, to see
What is
whether
your comment about?
The patient came to me with this ECG. Later on, I did another ECG, and I will show you later on. But I want to get some glimpse of from this ECG from anyone.
Sir, if we see at the lead V2, sir, there we can see, sir, right bundle batch block may be a possibility, sir. Or can we go for?
If you see the V1, is there any right bundle branch block like ECG?
No, sir. V1 does not give any picture like that, sir.
Okay, that's a good point. Here there is V2 is there is a RBB like features. Okay.
So can I
and QOA inversion, right? Dr. Arafat.
Sir, sorry, sir, I could not understand, sir.
Actually, V2, there is a T wave inversion as well, is it?
Sir, right, sir. Okay. Sir, right, sir.
Okay. Can we? I go for next ECG. This is the next ECG. Patient patient came to me with the previous ECG. Then I repeated the ECG, and this ECG we could find. Now, Dr. Arafat, you would be able to interpret this ECG more easily.
Sir, right, sir. Here I can see, sir, there is ST elevation with downsloping elevation, sir, I can say. And there is also, sir, right bundle batch block pattern here. And deep T wave inversion, that is symmetrical. And there is also some reciprocal changes in lead 2, 3. And
whenever you get this type of ECG, just remember this ECG. This is a classical shoulder down RBB presentation, as Hafiz Bhai always says.
Sorry, sir.
So,
shoulder inversion. Possibility of, you have to name something, a syndrome.
Sir,
May I make a comment?
the
Yeah.
Wallenberg syndrome, sir, is it a Wallenberg syndrome? Sir?
No.
Hafiz,
No.
please.
That's okay. So Shafique bhai, can you please go back to the previous EKG?
Okay, sir.
So I just wanted to tell or request all the participants, when you are faced with the EKG, it is a clue. It may not give you the whole diagnosis, and actually in real life and also in the exam situation or a forum like this, the presenter actually give you a clue. I mean, if you look at the history, there is a
Yes, sir.
reason why Shafique bhai has given a very short note, but very relevant note. Look at how this patient is presenting, and he is giving the EKG. So I will stop there. Let's point out how the patient presented, and then look at the EKG. Now, Arafat, any comment?
Can I make any comment?
Yes, sir, please.
Yes, sir.
So let's stick to lead V2 and its RSR pattern. And if I measure the QRS duration, it's about 160 milliseconds. If this is right bundle, I would have seen similar pattern in lead 1. In lead 1, actually QRS duration is normal. And there is no terminal S wave. Same in lead V6. QRS duration. That means what I am seeing in lead V2, that second R wave is not R wave, actually. And if you draw a line, in lead V2, the second QRS actually ends with at a line, you can see it. And if you go down straight, you will find that in V6, that's in the ST segment. So even with this subtle change, even though it looks RSR, actually that's the ST segment. Now, Dr. Shafique gave you all the clues in this, but I have a similar patient who just presented with flu-like syndrome symptom and had no history of dizziness or patient. But this typical ECG is very, very typical. And actually, a couple of doctors, young doctors, have already answered it in the chat line. So I'm very happy with that. So please continue. Those are the things that when you interpret, Hafiz mentioned the clinical scenario. Second, look at lead V2, the duration is wide, but in other leads, it doesn't look wide. That means that wideness is probably not from the QRS. It's probably from the ST segment. Well, this is a great.
Shafique bhai, next EKG. Next one.
I think the first ECG is more important, and then the second. Second one is pretty clear ECG.
Very clear.
And as Hafiz always describes, shoulder down. Hafiz, go ahead.
I will be very sad. Anybody participating in this forum would be considering thrombolytics or coronary angiogram. I'll be very sad.
Hopefully not.
So this is the benefit of doing this kind of discussion.
Right, sir. So if we go into the details of Brugada syndrome, just to have a glimpse on Brugada syndrome.
Wait, one second. I just, if you allow me to say this. So okay, in life, say that, it's not like cricket that we just go for a 6 and then become a hero. If you can, that's all and good, but have a differential. If this patient has palpitation, 36-year-old, and ST elevation and this pattern, and you are confusing with STEMI or, make a differential about Brugada, but still you are in doubt and somebody on your nerves, what else you can do in the acute setting in the emergency room?
Hafiz, can I add something?
Yeah.
In that case, I will always look for reciprocal change in the inferior leads. In the case of acute ST-elevated anteroseptal MI, you are very likely to get some ST depression in the inferior leads.
Right. But if you know that, Wadud, then you probably know the whole story. But some people may be still confused and maybe still like, oh, reciprocal change, if you get it, then it supports. But if not, doesn't exclude, and it's still in doubt. What else we can do? If it is, resolving this. Transmural MI usually gives LV wall motion. If the LV wall motion is normal, ultrasound can be really helpful. And take a careful family history. Shafique bhai mentioned family history. I actually wanted to ask, ask the presenter that if the family history positive for premature coronary artery disease, or family history present for sudden cardiac death.
Patient does, yes, sir. Patient does not have any history of sudden cardiac death, and we did Holter ECG monitoring. We could not find any sorts of arrhythmia during the 24 hours period, and also patient did not complain any sorts of palpitation during the period.
Right.
Hafiz bhai.
Yeah.
Hello, Hafiz bhai.
Ji.
In all the ECG textbook, the shape of the ST segment in this ECG, what is highlighted in the V2, is always stressed there. What should be the shape of the ST segment in case of the Brugada syndrome? And seeing this shape, I think it is very much difficult to compare this ECG with the ST segment, that is ST elevated myocardial
I totally agree with you. I totally agree. You have to be familiar with this shape, and you need to know that this is characteristic of Brugada. And then it will be, that's why I said, I will be very sad if anybody attending this meeting will ever give thrombolytics or stat coronary angiogram for this. However, having said that, we have been fooled. Many people have done coronary angiogram, and after that, they call the other guys.
Sorry, can I please say one
can
thing?
Hafiz bhai, can I add one point?
Yeah.
Hafiz bhai?
Sure.
Yes, Azam.
আচ্ছা ফিরোজ ভাই যেটা বলছিলাম যে এই ইসিজি দেখে যে লাইটিক্স দিবে এটা মোস্ট আনলাইকলি, নাম্বার ওয়ান। ক্লিনিক্যালি যে প্রেজেন্টেশনটা থাকবে চেস্ট পেইন, এটা তো ফার্স্ট আমাকে বের করতে হবে। যদি চেস্ট পেইন থাকে তারপরেও তো আমাকে মানে 3 বার চিন্তা করতে হবে লাইটিক্স দেওয়ার আগে, বিকজ দিস ইজ নট টিপিক্যাল এলিভেশন, দিস হ্যাজ এ ডেফিনেটিভ শেপ, দিস শেপ গিভস ইউ আদার ক্লু। সো আমার মনে হয় না এখানে কেমন একটা মেজর ভুল করবে সবাই, আমি যা দেখলাম আর কি। ইটস মাই ওপিনিয়ন।
আজম, আমি দেখছি ভুল এখানে, এবং that's why I'm saying that is very important. However, I have one question that if you don't have you are not lucky enough that you have the second EKG to induce Brugada, what you can do? Probably this is beyond me. This is actually EP question.
EP question, also some drugs.
Okay, I think Shafique bhai can go on for the next slide.
Sir, can I please say,
that is the part where he's going to tell about Brugada.
Right. It is an autosomal dominant disease inherited from inherited disease, and this sodium channel defect, and 60 different mutations in SCN5 chromosome 3. Right. Epicardial area of the RV usually repolarized abnormality, prone to some spontaneous ventricular arrhythmias, especially ventricular tachycardia or ventricular fibrillation. Prevalent in Southeast Asia. This is very important, and 9 times more common in male. Symptoms often first occur in 3rd and 4th decades at rest or during sleep. This is very important. And Brugada syndrome is of 3 types. I have shown you the type 1, right? Type 1, and there's 2 different types are type 2 and type 3, where the in type 1 you will get ST elevation coped type, and both 2 and 3 it is settleback, where ST elevation in 2 it is more than 1 millimeter, and in 3 it is less than 1 millimeter. That is the basic difference between type 2 and type 3. So this is in 3 types we can get the Brugada syndrome. And I'm not going in details because there are so many things yet to say how Brugada syndrome can be induced, what are the causes, and of course if patient having fever, hyperthermia, in that case Brugada syndrome can be induced, and perfectly one can get the type of Brugada syndrome. That is also important in fever and hyperthermia. And also some drugs, especially sodium channel blockers, procodamide, azlamine, and so many drugs. Okay, tricyclic antidepressant, also important drugs. So that need to be patient should not get this source of drug. And treatment is very difficult because no drug can help. Only quinidine is the one drug that can help Brugada syndrome. And ICD is the mainstay of treatment for this patient. And if patient having repeated shock, in that case, quinidine might help to reduce the shock events. And later on, I can, this is one, another ECG.
Shafique, how did you manage this patient? The previous one?
Brugada syndrome, usually if it is asymptomatic, no need to give any treatment. Patient having history of cardiac arrest, or patient having history of palpitation, and that can be seen through by any means, that is 24 hours or 36 hours or 72 hours Holter ECG monitoring. If we get any sorts of ventricular arrhythmia, then definitely ICD is the mainstay of treatment.
But did you do this to this patient? What management you have given to this patient? This patient is symptomatic.
This patient, actually, we could not yet detect the ventricular arrhythmia, because patient, we did 24 hours Holter ECG monitoring. Later on, we suggested to do 3 days Holter ECG monitoring if patients having these sorts of palpitation still persist. That is the idea. And patient, if patient do persist palpitation, then he will come. We will do 3-day Holter monitoring. So if we can document the ventricular arrhythmias, then we will put definitely one ICD for this patient.
Hello, Dr. Shafique.
Yes, sir.
Can I ask a question to you and Rafik, sir? Hello, sir.
Yes, go ahead.
Sir, sometimes we get the patient of Brugada syndrome like this, and some confusing symptom, like sometimes he describes that he has got palpitation and some pre-syncope, but definitely negative family history and no definite history of the cardiac arrest or definite ventricular arrhythmia, and the Holter is also negative. Sir, what should be approach in this case, sir?
Right. Very good question for me as well.
Okay. I'll tell you something. So I had a patient who came with flu-like symptom and had Brugada ECG. That is one way it can manifest. This group is a diverse group of patients. It's very difficult. I mean, what Dr. Shafique did for this patient is appropriate. I would refer you to a very good article recently published in Journal American College of Cardiology. If you want, I can email it to you. What Brugada brothers have done, they have gone through all the patients that had sudden death, and they followed them and came up with a 16 points and looked at the relative strength of each point in evaluating this patient. Even, I mean, that has not been accepted yet, but I think it's a very, very good article that I'm going to send to you. But at this point, this patient, without any family history of sudden death, no history of syncope, because dizziness, remember, can be a non-specific symptom also. That's the problem part. I think this is the right thing to do. The problem is, how long are you going to monitor this patient? 1 day, 2 days, 3 months, 6 months? We don't know. Nobody knows that. So, and the drug provocation study is irrelevant in this patient because it's already there. The role of electrophysiology study is also controversial in this group of patients. So there you go. So I'm going to send you the paper and you can distribute it among the audience. So Atahar, I'm going to send it to you.
Okay, sir.
All right.
Thank you, sir. Shafique, you can proceed.
Okay, this is the next ECG. Anyone volunteer can say?
Any of the fellows or audience who are interested?
এই আমাদের বিদেশি ফেলোরা করতেছে না?
Anyone from Nepal?
No one. We have but Lieutenant Colonel Nizamul Hussain. Dr. Nizamul Hussain, do you want to make some comment?
You can ask a few of the Nepalese guys here.
Okay, Maski,
like,
you can...
yeah.
Who are interested, please raise your hands.
No, I'm checking who is here. You can ask Arjun Budatoki, he's here. Can you make him panelist? Arjun K. Budatoki.
In our opinion.
Ribhu, Arjun, make panelist.
Yes, sir, made him panelist, sir.
Okay, Arjun, you can answer now. Arjun, you are there? Arjun,
Yes.
Hello.
Dr. Arjun, can you make some?
Hello.
Yes, we can hear you.
Good evening, sir.
Okay.
So, am I audible, sir?
You are audible.
Hello.
Yes, you are audible.
You are audible.
Please go on.
Hello.
Yes, you are audible.
Yeah.
Please.
Yes,
Go
sir.
ahead.
So this is a 12-lead ECG, which shows a white QRS complex. There is a pacing spike seen before the QRS complex. So A sense B pace, and the rate is 2, 3, 4, 70, around 70, and 2, 3 AVF. So this is a paced rhythm with
What is the atrial rhythm, and is there any synchrony between atrial and ventricular rhythm?
There is no synchrony between the atrial and ventricular.
And what is the atrial rhythm?
The atrial
This
rhythm.
is single chamber pacemaker pacing or double chamber?
Hello.
Is it a single chamber or double chamber? Can you hear me, Mr. Arjun?
Yes, sir. Yes, sir.
Is it a single chamber pacing ECG or double chamber pacing ECG?
Single chamber pacing, sir.
Okay, fine. And is there any other things need to be?
There's no synchrony between the atrial and ventricular pressure. So looks like
Rhythm is regular, right?
Concentrate on the isoelectric line.
Yes, sir.
What do you find?
Sir.
Dr. Arjun?
Dr. Arjun?
Yes, sir.
What is about the isoelectric line?
Finding the electric line, it is flat or there is something?
What is the P wave?
I can't hear you, sir.
What is the P wave?
Yes.
The question is it under rhythm is sinus, or is there something else? What do you find if you look at the lead 2 or V1?
2, 3.
The length.
The rhythm is not sinus, sir.
What type of rhythm it is?
It's atrial. Well, atrial tachycardia, sir.
Atrial tachycardia, very likely. All right. Now, why it is not atrial flutter?
Yeah, likely, sir.
Likely. So, what is the rate of atrial flutter?
The rate is about 300, sir.
Almost.
Right.
Yeah.
300. Atrial
Yes, sir.
flutter. So,
Yes, sir.
and patient having the ejection fraction is 35%. So, this is a ICM patient, right? And patient was done ICD.
Yes.
ICD was implanted. So atrial flutter patient, ICM patient, and with complete heart block. That is also very important, right?
Yes, sir. Yeah, because there is no synchrony between the atrial and ventricular contractions.
Can I make a comment on this?
Sir, can I ask you a question? How differentiate atrial flutter and atrial tachycardia? Because looking at V1, the P wave looks like biphasic. So is it flutter or tachycardia? Atrial tachycardia.
Let me make some comment on this.
Yes, sir.
First of all, I think Arjun answered very nicely. I mean, it's a single chamber pacemaker. I think if somebody can mention that, I'll be very, very happy. As an instructor, I can never ask is it a dual chamber pacemaker or a single chamber pacemaker? Only answer that can be made from this ECG is single chamber pacing. It can be a dual chamber pacemaker which has mode switched. So when you describe paced rhythm, it's always good to see what is the underlying. So what we do, we report ventricular paced rhythm with underlying atrial flutter or underlying sinus rhythm or underlying atrial fibrillation. And it is a good thing to mention. So please practice that, whatever the young doctors here. So please try to mention what is the underlying rhythm. Sometimes in very fine atrial fibrillation, it becomes very, very difficult to see anything. It just shows a flat line. I mean, then you can't say anything, but it's good to make a comment on that. Why that is important? Why? Because let's say my patient has a single chamber pacemaker, goes into atrial fibrillation, and I never diagnosed, and patient ends up with stroke and anticoagulation. That's important. So those are the two things. So I think other part. So the question is it atrial flutter or atrial tachycardia? Mechanistically, if you look at lead V1, it looks like discrete P wave. In flutter, you don't see the, but actually in V1, even in typical flutter, you can see discrete P wave. So that's the distinction between atrial tachycardia and atrial flutter basically becomes the rate cutoff. And I think there is significant overlap in this diagnosis. So if it is this one, I'll call atrial flutter. If the same thing was at a rate of 130, I'll probably call it atrial tachycardia. So I think, the question is with the mechanism-wise, both can be a reentry. A macro reentry or micro reentry. That will be an EP doctor to decide. So from our clinical standpoint, I believe that if the rate is below 150, it is wiser to call it atrial tachycardia as long as there is discrete P waves. If the rate goes over 200, then clearly it's, I'll bet more on atrial flutter clinical diagnosis than atrial tachycardia.
Thank you, sir.
So may I please ask a question, sir?
Go ahead.
Sure.
Sir, once I have read that the direction of P wave in case of atrial flutter varies in lead 2 and V1. If it is positive in lead V1, that its direction will be negative in case of lead 2. And vice versa in case of the direction of the wave according to anti-clockwise or clockwise, sir. Here I can see the direction of the P wave is positive. The peak of the P wave is both positive in V1 and lead 2, sir. But here the rate is also very high here. So can we say it atrial flutter here or anything else, sir?
I'll call this atrial flutter. And you pointed a very nice, if you look at lead 2, 3, it looks upright. So this is actually a clockwise flutter, more likely clockwise than counterclockwise. And the counterclockwise will become the typical sawtooth appearance. So I think by definition, this will be atrial flutter.
Sir, thank you, sir.
Thank you, sir. Shafique bhai, your next one.
So patient having ICD.
Can I have a...
And this is a COVID patient, actually.
Shafique.
COVID patient.
Shafique,
yes, sir.
Can I go back to the previous ECG?
Okay.
Sir, I have a question. This patient has EF of 35%. So if I can convert the flutter rhythm into sinus rhythm, there will be atrial contribution in the ejection fraction. So for that contribution, do you do the DC conversion for this patient? Do you advocate that?
I think I plan to. I think we should wait until he finishes the case.
Right.
I think this is a good point that we need to make. Dr. Shafique, please continue.
Actually, sir, this is a permanent atrial flutter. A patient, the previous ECG of last year, even the same ECG, and one day ICD was done. Right, sir. Because dual chamber could not be done because of atrial flutters. That was the decision taken from very beginning time. Okay, sir. And
okay, so I think the question that Wadud asked, I think if we go back to the ECG, I had a patient who presented to me with permanent atrial flutter since 2016. But There is a problem with that definition. Nobody ever attempted cardioversion in that patient. So if we use the term permanent atrial flutter, permanent atrial fibrillation, we must have failed medication or intervention. So if this patient never had cardioversion, I will not call it permanent. So I actually would have tried cardioversion, and because this is a patient who is 64-year-old with cardiomyopathy. Now, cardioverting this patient with a single chamber pacemaker, it's not going to help much. Actually, it will go back into flutter quickly. I mean, what this patient ideally should have had is at this point, the EF 35%, I'm sure has CHF, upgrade to a biventricular defibrillator with cardioversion and anticoagulation. And that will hopefully improve his ejection fraction and everything.
Yes.
And this actually, I'm skeptical about clinical data and review this again, because I get worried when the EF is 35%, because the number is at the fence. So I wanted to make sure that the 35%, how it is done, who is assessing the LVEF, and Shafique bhai, you have said the post PCI, is there anything we can do? Is it then, if it is not, then we are calling it ischemic cardiomyopathy with contribution of tachycardia cardiomyopathy? We don't know. So that needs to be addressed. And before we go for the permanent device, of course, ideal is to go for BIV, because this is going to be a big problem because it is paced all the time. So all these, I think, need to be addressed, because I'm not quite sure that when there is a number like 35%, we can jump on. We have here the benefit of using light vest, which is wearable jacket, and give all the guidelines directed medical therapy, including all pathways, reassess the LVEF, and then think about the device, particularly when we are on the fence.
But Hafiz, I think my assumption was this patient already had the ICD, so it must be old. So it must be a chronic cardiomyopathy that.
Okay, was it an ICD from before or pacemaker from before?
No, it's an ICD.
Perfect. Do you have any implantation?
ICD. Single chamber ICD.
No, before implantation, do you have any?
Actually, this patient, I did not see the patient previously. I was asked to see the patient having these sorts of ECG, and a patient was referred to see because patient having COVID. Patient was in COVID ward, and I have seen the patient and got this ECG, and this is the time probably I need to show this ECG.
Now, Shafique bhai, I want to know what is the reason for ICD implantation? What was the reason?
See, patient probably a patient having ventricular tachycardia previously.
He had a history of BTEC.
I don't know exactly. Actually, patient cannot give a good history. Even patient could not even show me the echocardiogram. We did the echocardiogram where we could find 35% ejection fraction. So patient cannot give all the data. And ICD was implanted outside of our outside country.
Okay, I got your point. But my question is, when you as a attending physician or as attending consultant, you have to definitely figure it out. What is the reason behind this and how to optimize our therapy, as well as medical management, because this patient is low ejection fraction. I don't know actually patient have a coronary disease or not, and what is the
patient already post PCA and ICM, and patient having anterior myocardial infarction on echocardiogram, and patient
that is the reason.
Right.
Patient has history of old MI and his post PCA status. That is different reason for ICM.
Right.
Okay. And what was the BNP level?
BNP level was elevated. Probably it was 3,000 to 4,000, something like that. BNP was elevated.
So is it, Rafiq sir, can you answer, sir? Do we need it for upgradation of the device? I think this is the particular case
Well, I mean, at this point, that's a mute issue because patient came with COVID. So the question would be, once the patient has recovered, then we decide whether, I mean, clearly, if the ejection fraction is that low and patient is symptomatic, then one has to consider upgrading to a biventricular system. Of course, it's very easy for me to say, but you have to remember the financial constraint in Bangladesh. The question would be, like, one of the things that we do, that if somebody has a device which has, somebody is on the background.
Professor Tawfiq, can you mute yourself? Professor Tawfiq, okay. Sir, you can go now.
So the timing, when is the timing? Let's say this patient, we make a decision that needs to be upgraded. And that is, the patient is not terribly symptomatic. You can wait a little bit, wait for the device when the time comes to, sometimes we wait until the device time comes to change it, depending on the symptom. If they're class 3, you, of course, do it now. But in this case, there is no reason to rush into those kind of decisions at this point.
Sir, I have a question.
Atahar, sir, unmute yourself.
Hello, sir.
Yes, sir.
Yes.
Sir, if elective cardioversion is planned for this patient, what will be the protocol of cardioversion, sir? By the device or the external cardioversion for this particular patient?
Yeah, so the Atahar is asking a very interesting question. Can I use a device to cardiovert? So a few things. One, definite anticoagulation. I mean, ideally, you can go by the traditional way of 6 weeks of anticoagulation followed by cardioversion. Other thing is that you can start anticoagulation with NOAC and then do a TE. Or nowadays, we are also doing CT to rule out clot, and then cardiovert. That's in the cardioversion. I have done with the device. It works in some cases, but not always. Remember, this patient has actually a single coil ICD, and that's only in the RV. And if it is more effective when there is dual coil, because if there is a 2 coil and the second coil is sitting next to the atrium, and that cardioversion works more. But I usually try one time through the device because patient under anesthesia do a cardioversion. This may convert, and then if it doesn't work, immediately switch to external cardioversion.
Thank you, sir.
I think we should proceed. Enough discussion on this.
Okay, sir. Thank you, sir, for a very good discussion. And this is another ECG. Patient came with chest pain for 4 hours. Anyone volunteer? Anyone volunteer can come up and comments. Anyone volunteer, please? Fellow, any fellow?
Dr. Arjun, can you make some comment? Dr. Arjun?
Yes, sir. So this is a 12-lead ECG showing ST elevation in 1 and AVL and reciprocal depressions in 3 and not much in AVL. There's so V5, V6. Hyperacute T waves in V2, V3, V4. So this is likely and STEMI, anterolateral wall MI.
Anterolateral, but you have told to only ST elevation in lead 1 and AVL. Why
the V2, V3 show a hyperacute T wave, sir.
Is there any ST elevation V2, V3, V4, V5 ST elevation?
It could just be a J point, but the T waves are hyperacute, sir.
T wave hyperacute, right?
Yes.
Okay. And there is a J point elevation. Is
yes,
it
sir.
J point elevation?
Yes, sir.
If it is
yes,
J point elevation, then what would be your diagnosis in this ECG? You are sticking on anterolateral or only high lateral?
1 and AVL clearly show ST elevation, sir. So High lateral
Upwards.
is, yeah. But
Here?
because the patient, this could be extensive anterior wall.
Anterior wall.
Patient profile is, the patient is hypertensive smoker and of 48 years of age and typically presented with chest pain for 4 hours.
Right. In that case, it is high lateral or anterior lateral?
Anterior lateral, sir.
Anterior lateral. So in V2, V3, V4, is it ischemia, that is ST elevation of like that of ST elevation myocardial infarction or not?
Professor Arun
This is J point elevation.
Can you make some comment on it? Professor Arun Masri.
Yeah, I mean, there's definitely a ST elevation in 1 AVL and J point elevation in V1, 2, 3, and there's ST elevation in 5 and 6. So what we need to see is presentations. And tall peak T waves may be a feature of hyperacute T waves. And of course, we'll have to rule out other causes like electrolyte imbalance, hyperkalemia. So what we need to see is in the context of chest pain and signs and symptoms, the first diagnosis is we should think of acute coronary syndrome, likely of anterior lateral MI.
Hafiz.
Can you look at the AVR? Is there any depression of the ST segment? Perfect.
Yes, sir.
In AVR, there is ST depression.
ST depression in AVR.
Yeah. And there is widespread ST elevation, and in most of the leads, the concavity is up.
Exactly.
And
this is like that of J point elevation, and
yeah, and in other leads, the concavity is up. It's not coved up.
But if you look at lead 6, V6 and V5,
V6.
Yeah, convexity is there. It's not concavity. No, V6 is convexity.
No. It's not the typical coved up.
And see, 1 in AVL is not concavity upwards.
1 in AVL is typical.
Yeah.
Hafiz sir.
And V6, yeah.
Hafiz sir, please.
Yeah, this is a tough one. And we can be here in all day and discussing the EKG, but let's do the differential. So I tell the fellows that when you cannot make up quickly, then go for a differential. Make sure that you're not missing anything. That's the clinical medicine. So what is the most likely top 3 diagnosis? So my rule is differential is 3 or 5. After 5, you are looking for Harrison or Braunwald's. So what are the top 3? Top 3 is acute anterolateral ST segment elevation MI or pericarditis.
Pericarditis.
I would not even go to the third one here because the patient is clinically presented. If it is in the office setting, then you can entertain J point elevation, but unlikely. And you can say LVH, which does not fulfill the whole criteria. So the tough is the anterolateral MI versus the pericarditis. Look at the patient. If this is a dialysis patient coming here and you hear a pericardial rub, then fine. If not, then just do a bedside ultrasound, see the wall motion. If it's hyperdynamic, and then buy time. However, I can tell you, I have ended up doing cath in this kind of patients. And I would be worried about giving lytics. I would be worried about giving anything. If you're in doubt, just go to the cath lab and find out and then do. Particularly in our place, we have this issue with the dot to balloon issues. In doubt, but this is the doubt. But if you ask me, I am in Las Vegas, I don't want to bet. But if you want me to bet, I would bet that this could be acute pericarditis. But I don't want to miss this acute anterolateral MI in this patient.
Okay, can I make a comment?
Yes, sir. Maybe add anything, sir?
Arafat, you want to say something?
Sir, sir, here I can see there is also peer depression in chest lead, sir, and peer elevation in AVR. And as there is diffuse ST elevation in most of the leads with concavity upwards, sir, I would like to go for pericarditis, sir, pericarditis.
Absolutely.
Thank you. Rafiq sir, please.
Okay. So as Hafiz mentioned, there are only 3 diagnoses. Hafiz did not want to mention the third one, but I have to. First one, acute myocardial infarction is important because that can kill the patient. Second is pericarditis. I can kill the patient because if I give heparin or thrombolytic, can develop tamponade. And the fourth one will be early repolarization. So let's go for the first, second, and the third one. Acute pericarditis and early repolarization. Actually, Wadud gave a very beautiful slide. If you look at V6 and V5, look at the ratio between ST elevation and the T wave. If it is more than 25%, then it is not early repolarization. And here, that takes it away. And then Dr. Arafat, the other thing is the extensive nature of the ST elevation from V1, almost V1 to V6. And Dr. Arafat mentioned there is actually PR depression in limb leads and in chest leads and also in 2-3. And the other thing is PR ST depression. Now, saying all that, but still a patient, 48-year-old presenting with smoker, it will be always, the question is, what is the character of the pain? And then, of course, as Hafiz mentioned, echo. And a few weeks ago, I showed a patient. After 2 days, we were forced to take the patient to the cath lab and found out the coronaries were normal. But we still did not give heparin. So those are the things that we have to keep it in mind. Thank you. This is a good ECG.
Thank you, sir.
You can continue.
Actually, this patient, we could not do angiogram because patient developed fever the first day. And that is why we did not do CAP. And we have given only Clexane, low molecular weight heparin. And then in the next day, we could find this ECG. And ST elevation in the leg 1 and AVN, it is elevated. And
what was the echo finding on the first day?
Echo findings was normal. Echo findings was normal. And troponin was also elevated. 3,000 troponin. Troponin was elevated. 3,000.
Okay.
Troponin 3,000.
So Shafique bhai, the fever was what fever?
Patient actually fever was there. Total count was higher, and we did not do. That is why we did not take the patient to cath lab. And on next 2 days later, patient himself taken DORB. That is why we could not connect with the patient. And
no, I'm saying that the fever was like 103 or 101.
101. Fever was 101.
That's a blessing. That's all. That's very good news. Because post-MI fever is not that high. So this is probably acute pericarditis. The troponin doesn't help because it's a perimyocarditis.
Yes.
And one of the things that question would be, would I have given anticoagulation?
Absolutely not.
That's the part that I would probably force the patient for a cath lab before I do anticoagulation, because my intervention can kill the patient. That is the problem part. If I give any kind of, true, troponin is elevated, but the clinical diagnosis with the fever, character of the pain, echo showing no wall motion abnormality, that's another big clue. And in that case, either I do nothing or do a cath, probably.
Can you do CT coronary angio?
If you buy time with the patient, the chest pain, how it is, and any positional change, all these can help you. And you can do SET or anything, CRP, all that. But bedside echo usually helps a lot not to go to the cath lab.
Actually, bedside echo, there was nothing. Ejection fraction was normal. There is no wall motion abnormality could be found on that period of moment. So that was a dilemma.
No collection in the pericardial sac?
No collection.
No, fluid you don't expect, because the more fluid pericarditis, the pericardial effusion is going to be not present. So that actually
What about doing CT coronary angio in this patient? So that will give a clue.
We don't need a CT. We are
No,
okay.
if you have a doubt of ACS versus pericarditis and patient with the fever. So if you do CT, if it has a good negative predictive value.
Dr. Maski, if you can do CT, but my question is, you can assure yourself, you don't need a CT to prove this once the fever and the echo is revealed, So, but anyway, I mean, you can do it to assure yourself, but sometimes,
No.
it's
Okay, can I bring the issue of the city? Look at the economics of it. In Bangladesh, I think it will cost 15,000 taka to do a CT angiogram, right?
More than that.
More than that, around 20,000.
And how much is the diagnostic catheterization?
Almost same.
Almost same.
So, and if I am trying to do something, I have to go for something that we can also convert into an intervention if need be.
Yes, sir.
Right.
So I think if I am doing anything, cost economics wise, or even all practicality purpose, everybody will probably do a cath rather than angiogram, CT angio. And I'm sure Hafiz and others will agree to that.
It's something different in my hospital. It costs around 8,000 Nepalese rupees for CT. Angiogram is 12,000.
Yes,
That's fallacy, yeah. So that's why if you have some doubt, you do a CT angio.
Thanks.
Sure.
We are running out of time.
NICVD,
Sir,
sir,
we are
in
running out.
NICVD, it cost much less.
Okay.
3 to 4
Dr. Shafique, thank you very much. It was a nice session by you. You have shown very good cases. We can move to our next session. In next session, our speaker is Professor Chowdhury Hafizullah Hasan, sir. Dr. Shafique, can you stop sharing your screen? And thank you very much once again.
I think it's already too late.
No, sir, it's not late, sir. You have got another 30, 40 minutes.
I can share the screen. Can you?
Yes. Hafiz, sir, you can now share your screen.
হাফিজ ভাই আমরা সুন্দরবনে মধু খাইছি এখন আপনার আমেরিকান মধু খাওয়ার জন্য অপেক্ষা করতেছি
Dr. Shafique, both of these cases are very good. These are practical and very relevant cases that you showed.
Thank you, sir.
So the more controversy you bring and more discussion, that means the thing was good. Can you see my screen?
Yeah.
Yes, sir.
So this is actually.
Hafiz, are you taking over my subject? You wanna?
I actually kept this for the same reason Rafiq bhai said. So we have our Wednesday conference, which is CAT conference, but Friday conference is EP, which of course Dr. Buraj chairs and Dr. Bonomari. But I just go there, I drink coffee and enjoy the discussion. But I supply the EKGs. So I tell the fellows which EKGs to bring for their attention. So let me show you this EKG first. So this EKG I gave to the fellow that to bring to the EP conference. You saw that I skipped quickly the history part. If you want the history, I can go back and give you the. So anyone to, so poor residents and fellows, they were like wondering what to say. I would tell any participant in this meeting, don't ever let the EKG intimidate you. Because if somebody gives you this EKG, just say that this is a EKG tracing. First of all, this is not pulse ox. This is EKG, not pulse oximetry. We can say that confidently. The EP guys cannot go and come after you. And it is tachycardia, right? This is tachycardia. It is white complex tachycardia. Say that. And then let the big boys take over. So this is white complex tachycardia. Is it regular or irregular? Regular. I said, okay, it's a regular white complex tachycardia. And what do you say now? This is the history. So non-ischemic cardiomyopathy, diagnosed with cardiac cath 3 weeks ago in another facility, came into our hospital. History of quote unquote AFib. They started on apixaban, this EKG, but in the ER, they gave adenosine, and this happened. I'm so sorry about this poor tracing, but you can probably see that the adenosine did break the tachycardia. So this EKG diagnosis. Rafiq bhai, I'm sure you're enjoying now. So the moment the fellow told me that the cath is done, and the cath was negative 2 weeks ago, and I said, okay, give it to the EP guys. So what do you think? Anyone? Jump in.
First of all,
so Rafiq bhai, I did not realize that you have. So this is the EKG, and then adenosine given, and then adenosine broke the tachy.
Atahar sir, please.
Abis bhai, this is the AV nodal dependent tachycardia, wide complex tachycardia, and from your adenosine test.
No.
It's
why is Atahar answering? Why not one of the young doctors?
But since Atahar bhai said something, I would request the junior faculty to note how carefully he chose the word. So this is what you do, right? Always don't let the EP or anybody intimidate you. Say regular wide complex tachycardia, and then start the discussion. Let the big boys take over. Adenosine broke the tachycardia. Atahar bhai said, adenosine dependent, the circuit was broken. Very well said, Atahar bhai.
AV node dependent wide complex.
No. I want why this patient has wide QRS tachycardia. Can you go back to that EKG, please?
Yes.
First, we see, okay, wide QRS tachycardia at a rate a little bit over 150.
Yeah.
And if it is VT, my patient's life can be at risk. And I am choosing adenosine based on what that my young doctors need to know. Why should I choose? I mean, I believe that adenosine was given and it converted. Sometimes adenosine converts also ventricular tachycardia. Why do you think? What is the point that you think that this is not VT? Anybody, any of the young doctors, can you bring up somebody, or somebody wants to comment on this?
Is the normal angiogram 2 weeks back?
No, I didn't even know that there was an angiogram.
Rafiq bhai is correct that at the time the fellow did not know.
Even it is normal angiogram, there might be underlying cardiomyopathy, myocarditis.
Yeah. Okay.
Those might lead to VT.
Okay, let me point out something.
Yeah, Rafiq bhai.
Look at lead 1, typical left bundle pattern, but this still can be VT. Look at the chest lead. Even though there is poor R wave progression, the initial R wave is very narrow.
Yes.
I'm sure if we had a more lateral lead, you will see typical left bundle pattern. So that is the only clue you have. Number one. Number two, look at the beginning of the QRS to the deepest point of the S wave. In lead V4, V5, V6, it's not over 100 milliseconds.
Yes.
So you have to go by some signs. I mean, we always talk about the algorithm. The algorithms are not just for the exam. It is for practical use. So if I use those points, in the presence of a left bundle, narrow initial R wave less than 30 milliseconds, which it is, and absence of QRS duration from the beginning of the R to the deepest point of SOF, less than 100 milliseconds in all the chest leads. That points towards a non-VT white QRS rhythm. And then I feel comfortable giving adenosine to this patient.
Okay, so the fellow did not know any of this. This is our first year fellow. The fellow actually went there. The blood pressure was good. Patient was not tolerating. And the question is it tolerated VT versus tolerated SVT? That hemodynamic compromise is never a good way of differentiating. But the adenosine did break the VT. And the question for you, Rafiq Bhai, is that after the break of the VT, you can see now the narrow complex and then white complex. And the white complex, this PVCs, and I'm calling it PVC, is actually when the patient is in VT similar. And moreover, this is the EKG after the patient in sinus rhythm. You can see the white complex, for example, in lead 1 and also in lead 2. This white complex looks like same as in VT.
Yes, but look at the P wave in the T wave. So even though assumption was that this white is a ventricular premature, it is not. It's actually supraventricular rhythm. The P is nosed, clearly nosed, and you can see the P wave in lead 1, lead 2, lead 3. So it's and basically, and if you look at the, this is interesting because if you look at the in lead 3, you can see the first beat is narrow, but the second and the third beat is wide. That's a left bundle aberration.
So do you think that it changed the axis and became wide, and you would think it's still aberration, or you will
this
still
is, yeah. Question is, if you look at the presence of, especially the presence of the first two QRS complexes being wide with presence of a P wave and the constant PR relation, that's a supraventricular rhythm. I mean, now more than before, I am very, very confident about it. So this is basically a supraventricular rhythm being conducted with a left bundle aberration.
Okay.
Sir,
This patient was admitted in the hospital and then went into this in the night.
Yes.
And now what?
Yeah, so look at the first two bits. So there is a supraventricular bigeminy. And before the white QRS, look at the first one is narrow, and then it goes into white QRS. So the coupling interval is not shorter at all.
First of all, we did not see any AFib that is in the patient's chart and was given Eliquis. So I always ask the fellows that look at all the data before you commit to anything, and don't believe anyone, just believe yourself, and look at the echo yourself, not the report, and then see. So we are doing our own echoes and we are looking at this. So what do you think? Now you're more in favor of AV nodal dependent supraventricular tachycardia, Rafiq Bhai?
Well, this is not a 12 lead. I mean, the rate is same as before. If you look at the rate that was there, and it's a similar rate. I mean, if you gave me just this, I'll have a hard time telling anything. Why? Because I'll tell you one thing. Look at the top strip, long RR followed by short RR, no aberration, and no change in RR interval, and it gets wider. And that with this one, I will not make any comment. I just say there is a premature rate followed by white QRS tachycardia, and I can go for the differential diagnosis. But the first two ECGs, I'm still going to stand for a supraventricular tachycardia with left bundle aberration. This one, if you give me just this one, I will not make any such comment.
So I call it, in the hospital, we have a lot of scientists, and this patient was kept NPO for sustained VT cardiomyopathy for ICD. And I said, oh, so so this whole thing made me dizzy about the whole management. So I said, okay, let's look at the whole data. So first of all, look at the echo, look at the cath, look at this. What is this sustained VT thing? Because of this was reported as sustained VT, and then adenosine sensitive VT. And then another scientist came in, can it be adenosine sensitive VT versus SVT? So first of all, there is no need for ICD yet, and because there's EF is good, and then cath is normal, and we are talking about wide complex tachycardia, and we are talking about what is the differential of that. And now to summarize this, this is adenosine sensitive wide complex tachycardia. Likely, Rafiq bhai, likely your vote is that this is SVT with aberrancy that is sensitive to adenosine, and it is probably almost confident that it is ablatable versus VT.
Okay. If I'm using supraventricular arrhythmia, I should not use the term adenosine sensitive. It will be only reserved for VT. The thing about adenosine sensitive VT is they are more likely to come from the left ventricle, mainly the vesicles. I mean, you can, so that would have given a right bundle morphology rather than left bundle. So I still, I mean, now this rhythm that you are showing, I mean, it's basically a, you can see it very, very clearly becoming from narrow to wide. I mean, that confirms my suspicion that this was just left bundle aberration.
Rafiq bhai, you said it so fast, many probably have not followed. Let me, so RVOT type, sometimes is sensitive to adenosine, or it is right bundle coming from the left ventricle, channelopathies that can be sensitive to adenosine. This was not any of those. So it is unlikely that this is adenosine sensitive VT. It's most likely SVT.
Yeah.
So we did not do any of this. Patient is going for EP ablation. I will keep you in. So that was our conclusion. And
what are the ejection fraction of his?
Ejection EF is normal.
Yeah. So that's good news.
Yeah. So the thing, another important thing, the patient was in tachy, and then it was done in another hospital. The EF in the setting of tachycardia, sometimes we overestimate the severity and report the EF as less. And so that is another problem sometimes we have with the, so this is the EKG of another patient. What do you think about this? I did not give any history because I did not have any history. I saw this EKG in the morning when I was looking at the overnight EKG, and I said, "Who? Was that
what level of potassium?"
Okay, yeah. So the Wadud is right on the case. So this patient, of course, I called the fellow, patient coded, and the rhythm, the mode of arrest was pulseless electrical activity, as you can imagine, because of the hyperkalemia. But look at this. This is what I called, and I'm actually submitting for publication that term, shark fin. I showed you shark fin. But if you look at this V5, V6, this is what I call the pectoral fin. If you look at the shark has a fin on the top. That is the proper shark fin. In the pectoral, underneath the shark, there is another fin called pectoral fin that looks like this. So I'm calling it pectoral fin. Pectoral fin actually is more likely of non-coronary related issues like hyperkalemia. And this is the reason why pectoral fin happens. If you look at the right bundle, typical right bundle appearance, look at V5, V6, the repolarization phase of the right bundle branch block appearance becomes like the pectoral fin. Like look at the V5, V6. So this patient goes into tachycardia with AP and all that. and ultimately patient died. We could not resuscitate. But this is a patient with dialysis and diabetic ketoacidosis. And
what is the potassium?
Potassium was actually not that high, but the acidosis was profound. And that's actually another important thing I wanted to mention, that if the acidosis is profound, even with potassium 5, you may see little problem. And that problem, unless we recognize by the EKG, because EKG and chest X-ray are the immediate tools that we have in the hospital. And if we are not very good in this, sometimes we miss the diagnosis. And in our hospital, there is another problem now that stat lab is coming late because the the glucose is sometimes so high, the lab gets obsessed and does not release the electrolytes because of the sodium issues. And they delay the reporting of the potassium, which I am talking to the lab that please report the potassium early on. But in any case, we should be able to recognize the hyperkalemia and then really understand this issue so we can take care of the patient.
Hafiz, can you go back to the ECG, please? So, all of you, the younger doctors, remember this picture. No, the other one. The one that, this is fine. Can you move forward, please? Yes, this ECG. Remember this. This is an ugly looking ECG. There can be only 3 possibilities. 1, hyperkalemia. Second, sometimes you can see ECG like this if patients are on high dose of class 1C antiarrhythmic medication and become tachycardic. And it can look like pseudobeat. And the other time that we see that when we quote patients, when they die, they develop agonal rhythm. These are the only 3 times that we see ECG like this. And all of those, of course, are serious issues. And the other thing Hafiz mentioned is very interesting, that the relation between the level of potassium and the EKG change, even though there is relation, but I think the acidosis plays a significant role. I have seen an ugly looking ECG with potassium of 5.6, which normally you will see ECG with a potassium level of 10. But having the suspicion of hyperkalemia is very, very important, because if we don't fix the hyperkalemia, you can keep trying to do all kinds of things, but nothing will work. Thank you.
And one of the notorious combination in my experience over the years is that end-stage renal disease patient, AFib, bowel ischemia, when they go for bowel ischemia and dissection, the acidosis becomes so profound, and the anesthesia docs, they call us with this EKG for a STEMI, and we said, yes, you're right. We're not going to take this patient to the cath lab, forget it. So this is very important that you negotiate, and if as a cardiologist, if you're called in, even if you know the diagnosis, my advice that you start treating the hyperkalemia acidosis and I tell the fellows, be respectful to the others and don't tell them that this is not a STEMI and all that. Tell them quietly later, because they are already exhausted and they think that cardiology will come and take over the patients and their problem will be solved. But that is not the case. But anyway, so
Hafiz bhai, is it possible due to tricyclic antidepressant overdose?
Tricyclic antidepressant, first of all, to start with like this is, if it is a start, then tricyclic antidepressant is out, because tricyclic antidepressant usually with tachycardia, not with this. But hypoxia, acidosis, bradycardia, white complex, start point is very important clue. And you are absolutely right, Azam, that in the ER, if it is a tachycardia, white complex, then it can be a differential of tricyclic antidepressant. But I have not seen this wide with tricyclic antidepressant. However, it is possible if they are already in hypotensive shock and late acidosis, but I have not seen one like this much. And pectoral fin with tricyclic antidepressant, actually, I have not seen any case report yet. And the term pectoral fin has not been coined yet. I'm going to propose this and then see whether I can get this published as quickly. I have a series of cases now, but this is very fascinating. But the ST segment elevation, like in this one, confuses people, and people are worried about, can it be STEMI, So that's another important issue.
Hafiz, I have philosophical comment about all this discussion that's going on amongst us.
Yeah.
All the young doctors that sitting, look at us. I mean, we are talking, discussing, and I'm feeling like a student that I am starting day one. That means after so many years of training, there are still things that we are learning and sharing with each other. And so it's a continuation. Look at the Professor Azam, Professor Wadud, Atahar, Hafiz, and all the senior professors here sitting. I mean, we are discussing, and there are things that sometimes we don't know. And it makes us humble in this. And at the same time, to tell you that it's a continuous process. You cannot stop learning. I mean, you learn something, you continue learning and refreshing your memories every day.
So there is a famous thing called judgment comes from experience, right? Judgment comes from experience, and bad experience gives you good judgment. So we have gone through all of bad experience, so this is another important EKG. What do you think about this one?
So anyway, you want any volunteer to answer this?
Mono Zarafat.
So let me give you the story. AFib, COPD, stage 4 lung cancer, and then patient went into respiratory failure, and then this EKG.
No takers for this ECG? What happened?
Any one of the fellows want to make any comment? You can raise your hands. Dr. Arafat.
Sir, I was trying to see the ECG, but in my screen, sir, now I can see the ECG, sir.
The rate is 75, so start from there.
Sir, the heart rate is 75, sir, around. And there is, sir, all the ROF's height is reduced, most probably due to, sir, COPD.
So, Arafat, let me show you that story. The COPD, lung cancer, AFib, and this is the MART. Our hospitals call it the emergency team, because the patient went to respiratory failure in the floor, and the team was called to evaluate this, that why the patient was suddenly respiratory distress, and then this EKG. And with that background, what will be your 1, 2, 3 immediate thoughts?
Sir, it can be a case of, sir, pericardial effusion.
Yes, no. Exactly.
No. So before that, please, what is the rhythm?
Okay.
Sir, it can be, sir, malignant pericardial effusion.
No. What is the rhythm? You said rate is 75, but what the rhythm is?
Sir, PR interval is a bit increased, sir. There will be, sir, first degree heart block.
Okay.
And sir, if we look at the lead V2, sir, there may be, sir, 2:1 block may be present, sir.
So look at the V2, like lot of P's and lot of atrial activity and less ventricular,
sir,
right?
3:1 block may be present, sir, along with PR prolonged. Sir, I cannot say it prolonged PR, but there is 3:1 block, I think, sir.
Yes. So what is it? Sinus rhythm with 3:1 block or something else?
What about the P in lead 2?
Sir, in lead 2, sir, the PFs are directed, the PFs are directed downwards. Is that a negative P? And sir, and
বাংলায় বলবো
it is positive, sir.
লিড 2 কে দেখে কি করাতের মতো মনে হচ্ছে? লিড 3 দেখলে করাত মনে হচ্ছে নাকি?
বলো আরাফাত, আর ইজ রেট?
No, lead 3 টা তো একেবারে করাতের ছবি না একটা কাটা করাত যে।
Maybe they are more familiar with sawtooth than Korat.
করাত বাঙালি
পুরাতন করাত।
হ্যাঁ পুরাতন করাত, এখন বাংলাদেশি ছিল তো চিনবে। Anyway, atrial flutter with low voltage ECG, and then you go by the differential diagnosis. You initially said COPD, but patient also arrested with PA.
Yeah.
Then you use, okay, go ahead.
So look at the bias between me and Rafiq bhai. The moment I was reading this EKG, I was thinking, flutter, atrial tach, it's semantic, and then heart rate. But I was fascinated with the voltage. Voltage is low. I said, is it in trouble? And the fellow said, yeah, he went into pericardial tamponade last night. So this is very important, that clinical correlation. And this is why we call this forum the ECG Basics and Beyond. And then this one, I show you. This, and I'll finish after this one.
Hafiz, how big was the effusion?
It was not that big. It was about 800 cc.
Okay. So one of the thing is that, like if you look at the ECG, that's only low voltage. There is no alternates. I mean, there is some correlation, right? If the bigger fluid, you get the alternates more. Is that true, Hafiz?
Yes, it is true. And then total alternates, you get even bigger. But also, pericardial tamponade is a 3D effect, meaning that it is the amount of volume and the pressure, and then and the time. In the cath lab, for example, if you have a perforation, you get like 200 cc, and then patient can rapidly compromise because rapid increase in volume and rapid increase in intrapericardial pressure can decompensate rapidly. On the other hand, in a hypothyroid patient, the pericardial effusion can accumulate, but the pressure does not rise, and over time tolerated better. So the volume does not mean a much compared to how rapidly it is accumulating and increasing the pressure. Dr. Morton Karn, who has the book, I had the privilege of working with him, and Morton has a famous thing, which I don't follow, that always put a catheter and measure the pericardial pressure. With the echo, I don't really care for that, because you rapidly need to tap the fluid, get the decompression, and you can do the science experiment later. But that's the practicality. So this is interesting.
Hafiz, I think I just want to echo your comment that we had more trouble with smaller effusion than bigger ones. I feel more comfortable when somebody has a huge amount of fluid, blood pressure is still 90, than somebody with a small amount of fluid and blood pressure of 90.
Absolutely,
no question
right.
about it.
And also, this is a already compromised patient with COPD, and then increased pressure can decompensate rapidly. Lately I'm using what they call the micropuncture needle, and if it is too bad, then I just do bedside. And I used to take the cath lab, but now I'm doing it as bedside, and then do a micropuncture needle, and then give a little amount of saline air mixed, and then see I'm in the pericardial fluid, then start draining once I'm sure. If you puncture the ventricle, no big deal, because the micropuncture, usually nothing happens. So this EKG is interesting, because the cath lab technician told me, they asked me to repeat the EKG because of the baseline artifact. He repeated, and is still getting the same thing, and gave me this EKG. What do you think was happening here? The patient is, there is no artifact that the echo tech could find out, because he tried many times and got the same. So we are using the CVRX, is a stimulator for the cardiomyopathy. It's a neuromodulator. So that gives you this kind of EKG, and also patient with left ventricular assist device can give you this EKG. This patient had left ventricular assist device. I told the echo tech, you'll never get a better EKG, because I take the name of the patient away. We have a bunch of patients with the left ventricular. I know the patient. I said, this is a LVAD patient. So I thought it is interesting to show you, because if you ever see this EKG, you immediately can figure out. Baseline artifact is a problem with the EKG, but some baseline artifacts can give you clue, like Parkinson's can give you some fine tremor baseline artifact, but this is a gross baseline artifact. And this is a characteristic of left ventricular assist device. And then sometimes we see that with the CVRX in my study patients. I see this. So I have
what was the hemodynamics? What was the blood pressure?
Oh, this is a HeartMate 3, and then the blood pressure is a mean pressure was like 80. Sometimes you don't see basic pressure.
So it also give a clue if blood pressure is okay, so it should be an artifact.
Yeah. So that's all I have. Thank you all.
Thank you.
Thank you very much.
Thank you. It was a brilliant session. We must thank Dr. Abu Muhammad Shafique and Professor Chowdhury Hafizullah Hasan sir for their brilliant presentation. To take some comments from our panelists. Abdul Jamil Bhai, your
Yes.
comments about today's session.
It was excellent. I was a learner here. I learned a lot.
Hello.
And Shafique's cases were excellent, and we often get this kind of ECGs and patients. And Hafiz Bhai always shows us excellent ECGs with new information. Thank you very much.
Thank you, Dr. Jamil. Professor Azam, you want to make
Thank you, Firoz Bhai. এখানে কমেন্ট করার কিছু নাই, এটা একটা শোনার বিষয় আর কি। I always love to hear our senior colleagues and from our fellows interaction. একটা জিনিস আমি বলতে পারি,
তোমার মাস্ক নাকি?
না ওই চেম্বার থেকে বেরিয়ে বাসার দিকে যাচ্ছে আর কি। না ওই আমার যেটা বলার বিষয় হচ্ছে যে আসলে আমি তো স্টেডিয়ামে খেলা দেখতাম আগে, স্টেডিয়ামে খেলা দেখতাম যে যারা গোল দিচ্ছে খালি মনে হতো যে ডান দিক দিয়ে মারলেই তো গোলটা হয়ে যেত। এটা একটা সিনারিও। আর একটা হচ্ছে ইসিজির ক্ষেত্রে যেটা হচ্ছে যে ওখানে দর্শকরা ভালো বলতে পারে কোন দিক দিয়ে মারলে গোলটা হবে, আর ইসিজি যে সেশন গুলোতে এখানে দর্শকরা ততটা বলতে পারে না যতটা বলতে পারে প্লেয়াররা যারা প্রেজেন্ট করে। এটা হলো বিগ ডিফারেন্স, এটা আমার কাছে মনে হয়েছে আর কি। তো যাই হোক, না এটা মাই অবজারভেশন স্যার। আরেকটা জিনিস হচ্ছে যে এত সুন্দর সুন্দর যদি ডিসকাশন হয়ে গেছে, আমার একটা প্রেজেন্টেশন দেওয়ার কথা ছিল, সবই আলোচনা হয়েছে, তাও আমি চেষ্টা করবো আর কি। সামনে বোধহয় আমার একটা আছে, ওটাতে আমি একটা স্লাইড দেখাতে চেষ্টা করবো। ধন্যবাদ সবাইকে।
Thank you very much. Professor Arun Maski.
Oh, this is always a wonderful ECG session. In fact, I'm learning as a student, and I have a good news to all of you. I presented one case which was ectopic atrial rhythm, absent right superior vena cava, persistent left superior vena cava draining through coronary sinus into RA. I sent that image to EuroPCR this 2021. They have accepted as image. And it's very good. I thank you all for giving this opportunity and
congratulations
for presenting that. So, and the other part is we have a lot of final year residents, cardiology residents. They find very useful, and they are so grateful to Wadud, Atahar, and Rafiq sir, our Firoz and all. So Hafiz Bhai, everybody, you all are doing good job, and it's fantastic sessions, very popular here. Thank you all.
Thank you, Professor Arun Maski. Now, may I request Professor Atahar sir to conclude the session.
First of all, I'd like to thank Dr. Abu Mohammad Shafique for a nice presentation today, and also Dr. Chowdhury Hafizul Hassan. Always he enjoys the sessions. And thanks to Ropik sir for finally coordinating the session. And thanks our all panelists, particularly Professor Mohsin Hussain, I can see, MG Azam, Urun Maski, Abdullah Jamil, and many others. And Ribu, thank you very much for coordinating everything. And in next Saturday, possibly Khaled Mohsin and his team from the Universal Medical College will present the ECG session. Rubik sir, the medical college will start the session from the next Saturday.
Yeah,
Wadud
thank
bhai?
you. Okay.
I'm really looking for that.
Hello, sir.
Thank you, sir. Thank you once again, Professor Chowdhury Hafizul Hassan sir and Dr. Abu Mohammad Shafique. I definitely believe Shafique bhai has got much more to show us. Because of time, we have to stop him at early, and we'll definitely listen to him. We'll see more ECG from Shafique bhai in the next session. Thank you, Shafique bhai. And thank you, Rafiq Ahmed sir, for teaching us so many things. I think we can stop tonight here. See you on next Saturday. Till then, good night.
Okay, see you.
Thank you everyone. Assalamu alaikum and good night.
আমার কাছে মনে হয় কি জানো, কম ইসিজি হোক, কিন্তু এই যে ডিসকাশন গুলো হয় ডিটেল, এটা বেটার।
হ্যাঁ,
এটা আমাদের শেখাটা অনেক ভালো হয়।
আচ্ছা, শফিকে
আমি একটা গল্প বলবো স্যার।
বলো ভাই।
একটা গল্প বলবো স্যার।
বলো ভাই।
রবীন্দ্রনাথ